Maybe I could direct the first question to Bhausab. Uh, Sorry, I'll wait for everyone to. If there is any difference
Correct.
in the indications.
So as far as bytes are considered, they are approved by Indian regulatory authorities based on the studies in the Western countries, and the approval more or less remains same. But I think there is a trick there. We are required to have them exposed to, for example, in myeloma space, I made a proteasome inhibitor and CD38 antibody, and we may have refractory patient but who has not received all this kind of line of therapy. So there may be a catch in that kind of thing. Coming to car indications, so basically we have access to our own indigenous cars, and these car registration trials were enrolling patient more or less in the lymphoma space based on, one is very clear relapse and refractory patient, but second is when there were no other options available, for example no access to treatment, and basically the people meeting the scholar criteria, and they were designed in a space that we have broader indications, so relapse refractory, BNHL and leukemias, that kind of thing. So we have slightly broader indications as compared to what we are in the Western countries where they define line of therapies and subtype of lymphomas.
I think the major issue is that the sequential steps in the way the lines of treatment happen here may not be the same. And so sometimes it may just come a bit forward rather than backward. Dr. Rajeev, we also have some CAR-T products now available in the country which is indigenous or semi-indigenous. So what were the products that are available in India, both in B-cell malignancy and myeloma?
Yeah, that you all know that the first indigenous CAR-T cell done at your place, at Trek, in June 2021, ImmunoAct. And then another trial that happened here in Narayana, Bangalore. So in association with Siddhartha Mukherjee and Mujumdar and Dr. Sharath is here. So these two are available, and DCGI approved ImmunoAct, and we are using that, many of the centers. As far as multiple myeloma, indigenous CAR-T cell therapy is concerned, that study is going on, pharma-sponsored study, but it is not still approved by DCGI to use in clinical practice, so it is on the trial basis.
Yes, so we have indigenous CAR-T, two in the lymphoma ALL space, and one in myeloma. The trial is ongoing from the Origin, which is a subsidiary of Dr. Reddy's lab. Now, when you compare it to what is there in US and China, because these are the two major countries who have done the maximum work in this space, you can see a lot of them are already commercially available. And of course, that's because of the research that they do in the two countries. Dibakar, do we have any available bites in India?
Yes, sir. For B-cell malignancies, I think glofitamab will be available, not yet available in the market. And for multiple myeloma, we have teclistamab right now, which is available with us.
And how is the access to both of them?
So, access means in terms of cost?
Cost as well as availability.
Availability, yeah, teclistamab is available, sir. I think the cost for 1 month prescription is around 15 lakh rupees. And for glofitamab, I don't know the cost yet. We have used as compassionate access, but that is at a very high cost. So I don't know what will be the cost in India after it is launched in India. So I have no idea.
Are there any indigenous bites which are being produced?
I am not aware of it, sir.
Sure. So as Dibakar said, at least two of them are getting available in the country. Many more may become available in the next few years. But it is more that I think we will need to have our indigenous production to bring down the cost of these bites. And I'm not going through this diagram. It just tells that there are so many antigens which can be targeted in many of the malignancies, which also includes AML. And this will be what the future will hold. And this, Sharath, I borrowed this slide from Sharath, which shows how many BCMA targeted and GPRC5D targeted bites are already available. I request Dr. Nupur and Sharad to, interject anywhere where they think that, they can comment. Now, this for Vishwadeep, it's easy to talk about what is available in some parts of the world, but, just to extrapolate and use it in our country is not easy. So, one of the most important question is, do we have the infrastructure in many of the institutes or hospitals, or what infrastructure is required for us to use either the CAR-T or the bites or cellular therapy of any kind?
So the infrastructure is basically similar to what we do for BMT, although it will be a bit more specialized. The training has to be in BMT and cellular therapy rather than only in BMT. But majority of the things which we follow for BMT will be taken, will take care of the patients in CAR-T cell or any cellular therapy. So we need trained physicians, either medical oncologists or hematologists, but they have to be trained in BMT or cellular therapy. Then nursing support is very important. Clean unit which will have HEPA filter and other facilities which prevents infection, especially in our scenario where there is a lot of construction going on and a lot of fungus is in the air. Then lab support is very important, including molecular, biochemistry, round the clock lab support. Blood bank is very important. Transfusion medicine plays a major role in these kind of therapies. Then molecular pathology has to be there. Other than that, and other departments like infectious disease, if there is a neurological eye cancers there, then neurology support, intensive care support is very important. So trained intensive care people who know what they are dealing with actually, because it's a new field. Many of the people have not experienced what is there to be, like what has to be monitored and what has to be done for these kind of complications. So to sum up, it requires a lot of infrastructure and a dedicated team which can take care of such patients. But most BMT centers have almost all the settings which are required.
So in a nutshell, whatever is required for transplant, you need it for cellular therapy. I have a question for Dr. Nupur. So are there any centers in US where they don't do transplant and then they do CAR-T and bites, or is it always center which has a transplant program?
So I think the bigger issue around CAR T cells is because it's a cellular product, you need FACT accreditation. And most transplant centers have that FACT accreditation. Having said that, we've moved to completely outpatient CARs as well as outpatient bispecifics, and that's largely because of the demands on the system. So although we keep saying, so I do think it's really important to educate people. You do not need the same criteria for transplant as you need for CAR T cells. And that part needs to be clearly sort of understood. We are not using high doses of chemotherapy. We're using very low doses. The risk of infection with the bispecifics, etc., is something which happens throughout the course of bispecific. With the CAR T cells, it's only in the first maybe 2 or 3 months. So it's largely more because of a cell therapy product. We do that outpatient though. That's why it's the transplant center. There are plenty of places, as long as you get the FACT accreditation, you do not have to do transplants, but you still can do cell therapy.
Sure.
I mean, just to add,
yes, Jared?
The management of CRS and ICANS is something which is the new thing here. You may be a transplant center. I mean, if you're doing haplos, you may have seen it, but otherwise, that's the crux of the situation which you need to know how to handle when you're undertaking these therapies.
Yes, and the expertise of handling cytokine is predominantly in centers which do a lot of haplotransplant. So this is our own ISBMT registry where till 2023 we had 120 centers nearly, and this is expanding. So there will be many centers in our country also who would have the expertise of using CAR-T and bites, and especially because there are quite a few transplant centers around. Dr. Sudhir, what are the toxicities with CAR and bites? You just enumerate and then we'll go on to each specific one.
As Sarasar has mentioned, like there are some side effects which are specific for the CARs and bite, like the CRS and ICANS. And now, since this indigenous CAR-T, there are many centers are now doing the CAR T-cell therapy in India. So we are at least tuned to manage CRS and ICANS. So in our Indian setting, more worried complications will be like the incident, the infections, maybe more both bacterial, viral, and fungal infections.
Sure. So, we'll come to each one of them because that is the mandate of this panel discussion. So you have the CRS, you have ICANS, you have HLH-like, mostly in CAR-T, and infections and cytopenia. And when it comes to infection, there will be a divergence of what we see in the West and what we see in India, as exemplified by Sharat's case. So between infusion-related reaction and CRS, this is predominantly in the space of bite rather than CAR-T. How do you differentiate between the two? Because both may present with nearly the same sort of symptoms. And this is for Dr. Avinash.
Yes, sir. So infusion-related reactions can be with anaphylaxis, which are immediate IgE mediated, and where there can be sudden hypotension, hypoxia, and we may need epinephrine. And IRR without anaphylaxis, they are cytokine mediated. They can be up to 6 hours after giving the infusion. And CRS, the risk of CRS starts 2 hours after infusion till the next infusion. So the symptoms of IRR are mainly local allergic reactions like, and sometimes there can be systemic effects also. There may be low-grade fever, but CRS always presents with high-grade persistent fever, and if the grade of CRS is high, there may be hypotension or hypoxia. So
this is very important, and this is for the younger people in the audience, that it is very important to differentiate what is an infusion-related reaction versus a cytokine release syndrome, because the managements are a bit different, though they may overlap. And within the 6 hours of infusion is what one would identify as an infusion-related, and CRS is usually after 6 to 8 hours, and it may go on depending on the tempo of the cytokine release. Bausab, how would you sort of diagnose and manage CRS?
Yeah, so I think one thing we dissected out initially was the initial reaction to infusion, but second thing is whether it's CRS or infection. That's the next dilemma which you face, and many time these people would be neutropenic at this time. So you'll have to have a clinical approach, clinical examination, looking at sites of infection, collecting cultures, and also inflammatory markers like CRP, ferritin, fibrinogen. It might help you to dissect the differential out. Once you look at CRS, I think being proactive, especially in the CART setting, would be useful. So having a grading system handy and acting immediately is useful. And if you go on to have a say prolonged grade 1 CRS, probably that's the best time to give the first dose of TOSI and do not allow it to escalate. Now we are becoming more and more proactive. And the moment you go on to the grade 2 CRS, probably your next agent has to be on board. At the same time, we have to be careful because next line is steroids, and we don't want these people to receive indiscriminate steroids. So that's the decision which one is faced. But the moment someone lands with hypotension and requiring ionotropes, probably that's the time when you would probably start your steroid dexamethasone. Further grade, probably it's a race against the time, so maybe increasing the dose of dexamethasone or bringing on to your additional backup agent like high dose methylprednisolone, or maybe if available anakinra would be useful. So definitely, if once you have CRS and it is full blown, you will know that it is CRS, but initial timely identification, ruling out infections, and timely first dose of TOSI would be useful.
Is there any marker which will diagnose CRS versus infections?
Most of the times after a few hours it is very clear. When you have the first few hours spike, you may not have everything. Definitely looking at ferritin, CRP, and if you have access, then doing cytokines would be very useful, because interferon, IL-10, etc. But most of the times they do not be available to you when you want to give the first dose.
Yeah, so this remains dilemma, because infections remain the most important differential diagnosis, because they're heavily treated, they're cytopenic, and with the MDRs that we face, it's very important. And as Dr. Bausab stated, that antibiotics probably will be used, even if you think that it may be CRS. And then there's this grading, which is very clear, and this Sharath has mentioned. And according to grades, the tocilizumab followed by dexamethasone are usually the backbone, and then IL-1 antagonist if it is severe. And and most of the times, at least in the bites, the tocilizumab and dexamethasone would hopefully be enough. ICANS is the second major complication, and Dr. Rajeev, how would you work up for ICANS?
Yeah, ICAN means that is a post-CAR T or bite followed by neurotoxicity. So one should be very vigilant about these findings. If the patient on round in clinical examination, if we see that the patient is not responding properly, not giving response, answering, so then we need to think that possibly there is a possibility of ICANS, and the duration is just after CRS or overlapping with CRS, 3 days to 2 weeks up to, and there can be delayed neurotoxicity also. And there are some scoring system, that is a IC coding system, which is like mini-mental scoring, almost like mini-mental scoring, and the scoring is from 0 to 10, 10 is optimum. And that scoring system, the way asking questions, asking to follow commands, and then deducting 10 from 100. So those things are there. And that needs to be followed, as well as the other neurological findings, like whether the patient is arousable or not spontaneously, whether the patient is arousable by verbal comment or by tactile stimulation, and whether there is features of seizure is there or not. So this accumulating all these findings, we grade ICANS from grade 1 to grade 4. Depending on that, we need to treat. The primary treatment is by steroid, mainly dexamethasone, by depending on whether 10 milligram OD or BD to 20 milligram QDS, depending on the grade. And often what happens, if it is grade 4, patient needs ITU admission, then we need to go for methylprednisolone rather than dexamethasone. And as often it is overlapping with CRS, so tocilizumab may play a role if it is associated with CRS.
So would you want to sort of exclude infections when you're looking at ICANS? Would you do a CSF?
Yeah, definitely. Definitely CSF needs to be done if the patient is having features of increased seizure, or patient is a high ICAN features, high grade. But the problem of CSF is often they have high ICT, and then there is a risk of doing CSF. So always we need to do the fundoscopy to see whether it is papilloedema or not. And if it is papilloedema, we have to be very conservative about doing CSF. We can treat conservatively, and once it is come down, papilloedema resolved, then we can do CSF.
So, when it just follows CRS, usually the diagnosis is more clear. If it doesn't follow CRS, then one has to be clear that it's ICANS is not encephalitis. And that's maybe the area where one may have to exclude infections. And as you said, steroids remain the backbone, and anticonvulsants even prophylactically. The HLH, which is seen more in CAR T rather than bites, Vishwadeep, when would you see it, and how do you look for it in patients who have received CAR T?
So as we, I don't have a first-hand experience in using CAR T, but we treat HLH left and right because of either malignancies with HLH or with the haplotransplant. We had seen a lot of patients who have persistent fever, and you find like ferritin is very high and fibrinogen is going down, there is transaminitis. So you can get an idea that fever is not subsiding, their cultures are negative, there is no focus of infection, and ferritin is going persistently high. Then you suspect that like this patient might have HLH. We might do bone marrow as if indicated, that might show hemophagocytosis. And essentially the management in immune effector cell CAR T cell, we pitch in faster. Like initially you can start with even anakinra and ruxolitinib, which we usually keep for as a backup in other HLH. We treat the primary cause and give steroids in routine HLH, but in immune effective cells, because we know it is going to happen because of the drugs we have given, so we can directly go on to the anakinra and ruxolitinib as first line rather than keeping them for later.
So that's right. Yes, sir, yes, Dr. Nupur. This is where I mean, how would in the West, when you think that it's an HLH, transiting from CRS and then going on to becoming an HLH, what is the protocol that MGH follows?
Yeah, so we are super vigilant about looking for HLH. The incidence is not that high, but if you have a very high disease burden patient, those are the ones who develop some of these side effects. So looking at ferritin, and if you have a high ferritin level, we treat pretty proactively using anakinra early, using steroids early, because you have this HLH overlap syndrome as well, and they're the ones who develop the late delayed neurotoxicity as well. So treating as early as possible is what we are doing, and mitigating it. And most of these patients, we do cover them with antibiotics because it's really hard to discriminate, since they're neutropenic, whether it's infection or any of these. So all of them are on broad spectrum antibiotics, and then we are very proactively treating.
So, the IL-1 antagonist may not be easily available. For us, ruxolitinib is very easily available. So what is your opinion on using ruxolitinib upfront?
So,
with
we
steroids.
have used Ruxo with steroids. It takes longer to work, and we've typically used it in patients who are not necessarily responding to anakinra. At a time when a patient has HLH, you give them anything and everything. So.
Sure. And that's exactly what is expected when someone has HLH. Now, the other important complications are hematotoxicity. So, transplant causes hematotoxicity, but even the other cellular therapies cause hematotoxicity. So this is for Dibakar. How would you work up patients who come with cytopenia, either with CAR-T or bites, and then how would you manage these, and can you predict hematotoxicity?
So not much experience with CARTs. How we use whenever we face febrile neutropenia or a patient is having thrombocytopenia, so we usually rule out infections, usually rule out HLH, and we usually see whether the patient has received any myelosuppressive medications, and then we withdraw those medications, and preemptively we can use, or prophylactically we can use GCSF. So there is a scoring system which is given, which if the patient has a high score, that is the hematotox score, this patient can be preemptively put on GCSF from day +2 or earlier, usually from day +2. If a patient has persistent febrile neutropenia of more than 7 days or 14 days, those patients also can be started earlier. And usually the norm is that if the cytopenia usually persists for 2 weeks, and if a patient is symptomatic, then we usually institute the GCSF later from day 14. Not much from experience, that is from the guidelines what I am saying. And about the prediction, there is a hematotox scoring which has hemoglobin, ANC, platelet count, CRP and ferritin. And based on the values, we usually score this patient into low and high risk, and accordingly we use supportive treatment. But we should remember that we have to rule out HLH first, because the treatment is little bit different, and sometimes putting the patient on GCSF can again increase the cytokine reactions and all. That's what we have to remember.
So,
On platelet, if the platelet is low, again we can give transfusion support. We can use thrombopoietin analogs, and if the hemoglobin is low, we can use blood transfusions.
so that's right. Most important is when to give GCSF is important. If you're thinking that there is some hypercytokinemia, then probably you will avoid the GCSF, and otherwise you can give GCSF, and that score is which is there can only help you to predict who would go into a prolonged cytopenia, and maybe you can give GCSF if the clinical condition is fine.
Yeah, Dr. Naveen, I think this is the most important side effects in our setting, specifically for bispecifics. I have one experience of teclistamab. I lost the patient within 30 days because of febrile neutropenia. Dr. Sharad also presented 3 cases. All the patients ultimately had febrile neutropenia and turned up into ICU.
So that was
I think
the question which I would ask Dr. Nupur. So, while we say that the transplant causes more morbidity and, the CAR-T causes less and bites, so, infections obviously remain prolonged, especially when you're giving bites and it is continuously being given for months. So, in the West, obviously, you don't have such multi-drug resistant infections, but is the mortality in CAR-T and bites apart from relapse? What's the commonest cause of mortality in your setting?
So a really important question, and I think we need to look more at non-myeloma related mortality. We show all of these amazing response curves, but these patients are dying of infection. It's more so in the bispecific world and not so much in the CAR T cell space, but in the bispecific what we do is dose attenuate. Just because it's weekly dosing doesn't mean you have to give it weekly. Just because, the beauty of teclistamab is it's a per kilogram dosing and you can dose reduce. What you see is the people who respond within the first 1 month. And you do not need to continue weekly tech on those people. I think we go very quickly to once a month. I tend to use ELRA more than teclistamab. It's fixed dosing, but even with the ELRA, a lot of patients do well with 44 milligrams of ELRA as opposed to 76. And we give it every other week or give it once a month. The other thing is with the bispecifics, very important, the first 1 week, we are allowed to use steroids. Short-term use of steroids is not going to diminish the efficacy of these TCRs. So use those, get them over the hump of CRS, and use GCSF early so that neutropenia is resolved, and then IVIG. We tend to use quite a lot of IVIG. We don't use prophylactic fluoroquinolones.
I think this is very important, especially in our country where, there's lots of infection. So, unless we know this, that, you can space it out and use it not the way it is supposed to be used, you will be able to get them out, because relapse is later. First, you have to get them over the infections. I think I'll skip on this because, for the constraints of time, it's basically what Dr. Nupur has already said, that the antimicrobial prophylaxis is possibly not, they don't do it. I don't think many of us also do with fluoroquinolone. But for Dr. Avinash, I would ask you, would you use antiviral and PCP antiprophylaxis?
So, I don't have experience of using bispecifics, but as per guidelines, we should use prophylaxis, antiviral, HSV, VJV prophylaxis, either acyclovir or valcyclovir, hepatitis B prophylaxis, PCP prophylaxis we should use.
And vaccination?
Yes, vaccination is must. So pre-CAR we should give flu and COVID vaccination, and at 3 month flu vaccination and COVID vaccination, at 6 month PCV20, every 2 months 3 doses. Then for hepatitis B at 6 month, 8 month and 1 year. Then hepatitis A 6 month and 1 year. And DTAP is there, that we should give at 6 month, TD at 8 month and TD again at 12 month. And Shingrix vaccination we should give at 1 year and 1.5 years. So these are the vaccinations we should follow.
So that's more or less what we do for transplant. So those centers who do transplant, the vaccination is an important component of cellular therapy. Now, I think I'm coming to the last part. Is there a difference in the side effects, the incidence of adverse events in CAR-T versus BiTEs, Bausab?
Yeah, obviously it will vary from product and target to target, but it looks like that cytokine-related side effects. So, CRS and ICANN are more in the acute phase with the CAR-T as compared to the T-cell engager. As opposed to that, because of the chronic exposure, T-cell engager leads to hypogammaglobulinemia, infections, and also specific on-target off-disease effect like maybe GPRC5D causing more nail and those kind of things. So definitely we get to pick and choose even if we have same target. Depending upon the disease also they vary. For example, myeloma, we tend to have more side effects with CAR-T as compared to the CAR-T results in lymphoma.
Yeah, so this is the end. These are the last two slides where you look at CAR-T, their complications less than 30 days, their complications between 30 to 90 and then later. And it's predominantly infections and how to treat them when you have immunoglobulin levels which are low. And of course, there will remain some T-cell defect also. When you look at the bispecific, this is more within 15-20 days of each injection. And then you can see that it starts maybe with an infusion-related reaction, and then the cytopenias may go on. That will possibly persist till the second and the third dose. And then again, this we have already discussed. So the long-term follow-up again is like transplant. You monitor them as long as you can, because some of them will come back with complications. I think we are at the end of this panel discussion, and thank you very much for all the panelists and the experts, Dr. Nupur and Sharad, for being part of this panel. Thank you.
Thank you, Naveen sir, for this interactive discussion. And before we conclude, for the last talk, some housekeeping announcements. We kindly drop your registration numbers at the registration desk in case you would like your credit points to be included in your certificates. Lunch would be served at the same spot where dinner was served, on the first floor cafeteria in phase 1. As we come, they say the quest for knowledge is endless. Even then, we arrive at the last talk, who is a professor of immunohematology and transfusion medicine, Medical College, Kolkata. Dr. Rajat Bajaj, who is a consultant hematologist at HCG Nagpur. Dr. Mipsim Lama, who is a clinical hematologist from Nepal. May I request the chairpersons to invite the speaker.
So we come to the concluding session of this enriching IMC. So I would like to call the first speaker, who needs no introduction, Dr.
Yeah, it's a pleasant duty to perform, and I will hope you will have a pleasure listening to it. I decided not to have any slide because that's a distractions. It's a story that I'm going to tell. So stories and slides will be disruptions. IMC 2025 was a success. There's no doubt about that. And to put it in the conference in perspective, let's remember modern day pioneers in the field who pushed the boundaries. Doctors Bob Kyle, Maury Gertz from Mayo Clinic, then Wallenstrom, Tim McElveen, let's not forget that, who was the pioneer in high-dose melphalan, Ray Pauls, Bud Balogi, Ken Anderson, Bob Sagels, Brian Dury, Raymond Alexanian. These are the people who kept the myeloma field alive and pushed boundaries. Close on the heels came Sundar Jagannath, Nikhil Munshi, Vincent Rajkumar, Sagar Lonial, Nupur Raje, Shaji Kumar, Prasant Kapoor, Ashutosh Vachlikar, Chandramouli, and these are all Indian diaspora and doing excellent amount of work, and always intending and enriching the whole world with the brilliance and the perseverance than many, many others across the world who are working in this field. After listening to those Indian diaspora and other speakers, you would agree that the scientific presentations could be a great art, each one delivering his or her own unique style and keeping you captivated. Some of these art are inherent, some are cultivated. That's life, that's science, and let's celebrate science. and we are believer in science. There are a lot of people who are non-believer in science. That's all right. Again, that's life. What drove them into this niche field? These people, those who are working in the field of myeloma, it's a very small field, a rare disease. Science is the common trait, and the desire to learn more and to do more. Coming to IM 2025, quiz, oral presentations, and e-posters must remain the integral part of this conference to stimulate the young minds, also to remind the older ones that how much behind they are in this field. Sundar said on the day one, have your principles or basics of a problem in mind, solutions will come. This is the principles and practice of medicines as we read in textbooks. They are principles which you take forward and bring practice. You do research, you do clinical trials. We know much more about myelomas now. 25 years ago, we didn't know about the free light chains. We called them non-secretory myelomas, nearly 15% of them. You can't imagine that. And would artificial intelligence rule us in designing algorithms in a better understanding of the disease and treatment? It's a work in progress. Brilliant minds will lead to logical ends, not the artificial intelligence, but the creator of the artificial intelligence. Treatment for myeloma is following the path of acute lymphoblastic leukemia. Initial treatment, hit it hard, continue with maintenance, and look for cure. MRD is the buzzword. New classes of drugs are being developed. We talk about possible quick cure, a word everybody wants to hear. Autotransplants remain the important part of treatment. Let's continue to offer it as long as possible before it goes into oblivion, before the naysayers of transplant raise the victory signs. That's not going to happen too soon, as we know at this moment of time. Novel immunotherapeutics approaches have raised tremendous hope for the patients who have failed initial lines of treatment. Whether those will claim victory over the current standard of care as the initial treatment, at least those with a very high-risk disease, for some subsets of patients, only time will tell. CAR-Ts are being manufactured in the country, and meaningful collaboration developing between academia and industry, certainly a good sign, a long overdue in the country. Integration of novel studies in the area of immunology, termed as immunizing, has brought us a new paradigm in the field of cancer. Plasma cell disorders, no exceptions. Dr. Munshi explained so eloquently. Understanding precursor cells and preventing them from becoming monsters, Dr. Saji and Dr. Vincent continue to work tirelessly in this field, as many others across the world. Let's not give secondary importance to the supportive care at the presentation or at relapse of a disease when a lengthy treatment is on. It's an integral part of total care. Drs. Dogra, Dr. Priya, Nupur, Rimpa, and others told you. In the clinic, for the clinicians, look at every case as a clinical trial. It will help you to get involved in the case always in a fresh mind and think ahead. Because we said that going by protocol, yes, going by protocol, but always protocols are there to break. Protocols are not there to follow all the time. You heard Dr. Nikhil Munshi's keynote address, which is a pointer to the way the field is moving at a breakneck speed, delving deeper, digging more, raising hopes for understanding the disease better, developing new therapeutics. Refresh your basic sciences and keep looking for clinical trials. Collaboration is the key. Beyond the common plasma cell disorders, there are many unknown and lesser known clonal disorders. Monoclonal gammopathy is of clinical significance. Dr. Maman and Dr. Sundar introduced in a nutshell. We are just not able to identify them in our clinic as our minds are not open to those. On the final day, we saw in the PCP how challenging some cases could be in this field. There's so much more to know. Dr. Wachlekar updated on amyloidosis, a rather difficult clinical condition, moving from an oral alkylator to daratumumab-based treatment, and where transplant continues to play an important role. Dr. Sharat and Dr. Nupur spoke about the fascinating, exciting, and burgeoning field of immunotherapeutics. It has been a conference of imparting and imbibing of new knowledge. We are thankful to our friends from abroad, traveling far year after year to be with you, developing new relationships, rekindling the old ones. Bahut bahut shukriya to the hosts at the TMC, so ably led by Dr. Rina Nair. We were neighbors at Mumbai for many, many years when we were working at Tata Hospital. Dr. Deepak Mishra, Dr. Moir Parihari, and all the young colleagues in the department, in the hospital, office bearers of image. It has been an enriching 3 days. The event management team, River Route people, made our travel and stay so enjoyable. Have a safe trip home, and let's meet at the beautiful city of Cochin in 2026, to be hosted by Dr. Neeraj Sridharan and colleagues. Have a great year ahead. Manage your people diagnosed with PCDs with new vigor and compassion. So long, City of Joy. Thank you.
Thank you, sir, for your beautiful and nice summarize all these 3 days conference. Actually, to the organizer. Is there any talk?
No.
Because
Thank you, chairpersons, and thank you, sir.
okay.
So, thank you, chairpersons. Thank you, sir. We'll request Dr.
Thanks for being here till the last session. I hope all the prize winners are here. Okay, so I would like to thank our senior most EC, Dr. Tapan sir, for summarizing and for conducting or conveying the vote of thanks. So we are left with only the last job, that is to announce the winners. And this year, Reena ma'am had decided that we will have the respective conductors of the event, or the moderators of the event, or the judges of the event, depending upon whoever is available currently, to come and announce their respective winners. So for the first one, we would, for the best paper presentation, can I have the Dr. Arun, who was conducting the event, to come and announce the first, second, and third prizes. And what they get, I will announce it later. So, but let's first have the winners for the conference, for the event.
To the 3 best oral paper sessions. Dr. Chandramali, please. Pratishta Madan from ACTREC, and she was discussing about the prognostic relevance of a peripheral blood MRD in myeloma. Dr. Pratishta, please. The runner-up for this year's second best oral paper is being awarded to Dr. Nikita for discussing the work they did on DNA methylation landscapes in MGUS and myeloma. Dr. Nikita, please come over and collect your certificate. And the best paper for this year goes to ACTREC for their beautiful paper on the outcomes of autologous transplant in myeloma as per Melphalan-Dors. And that's a 15-year retrospective institutional analysis. And it goes to Dr. Sumit Mirk from the institute. Please come over.
Thank you, Dr. Molly. Heartiest congratulations to all the winners. So now comes the story that what are they going to get. So first of all, the executive committee this year had decided we are not giving any prizes for the faculty, though not unlike ISBBT. There are no change of the prizes. The marking has been absolutely the way it has been. So Reena ma'am was very clear that no marking will be changed, no changes done in the scoring post-event and others. So these are as it is what has been marked by the judges. But the faculty won't get any cash prizes or any awards other than the certificate that has been given. So this year, the only fellow who is participating, this is primarily to encourage more and more students to be benefited out of this whole thing. So the best student gets 50,000 rupees as a travel fellowship to any international institute or any conference. But for getting that, there are few preconditions. Yesterday we have shown a grid here. So that grid will be applied to put it in the simplified version, but the grid will be available on the website in the next few days. But to put it in the broad one, you have to be a member of Image, number one. Number two, you need to publish this or actively participate in Image activities. So publish it from your institute and just send her that copy of your publication of what you have presented, or participate in the Image activities as per the grid, and you get this amount. You are allowed to use this amount over the next 1 year at any point of time for any traveling for myeloma, in the field of myeloma, or for myeloma fellowships. So that's where we are. So for the next category, which is mini orals, I would request Hari Menon sir to come and declare the awardees or the winners. We have this year, because of the number of abstracts that we have categorized them into 3 groups: pathology group, clinical group, and other plasma cell dyscrasias, because we understand it's not easy to compare apples with oranges, as Naveen sir keeps saying apples and oranges. So we cannot compare apples with oranges. So we have first, second, third for pathology, first, second, third for clinical myeloma, and first, second, third for other plasma cell dyscrasias, which is amyloidosis, Waldenstrom's, and other poems and other categories. So can I have Dr. Hari Menon sir to come and declare the winners? And for giving away the prizes for the first category, that is pathology category, we can have Deepak Mishra sir to come and give away the prizes in the pathology category. No, sir, you are well dressed.
Thank you, Uday, and a wonderful meeting, wonderful 3 days, and a culmination of the awards for the mini orals. So we'll first have the pathology and the diagnostic category, and as is norm, we will start with the third prize, and that goes to Deepa Lakshmi on her mass spectrometric exploration of biclonal gammopathy, diagnosis, evidence, and therapeutic inference. Is Deepa Lakshmi there?
Anybody from the institute?
Or anybody from the institution?
From the same institute? Yeah, please.
Come. Yeah, please. Thank you. Congratulations. Yeah. And to announce the second prize, it goes to Satya P. for her talk on presentation on immunophenotypic profile and measurable residual disease monitoring in multiple myeloma and experience from a tertiary cancer center. Satya. Yeah, Dr. Satya is from JIPMA. Yeah, sorry. Congratulations. Yes, thank you. And the first prize in this category of mini-oral pathology and diagnostic goes to Rashmi GS, estimating the reference interval for soluble B-cell maturation antigen in healthy South Indian adults. Rashmi, you're from Amrita. Yeah, Rashmi is from Amrita Institute. Thank you. So So may I invite Dr. Maman sir to please come for giving away the certificate and the prize for mini orals in clinical. So thank you, sir. In the third prize for the clinical mini oral, we have Celine Raphael. Is Celine Raphael here? Yes, okay. And for the treatment, accessibility, availability, and healthcare costs for multiple myeloma in South Asian countries. And the second prize goes to Rupika Pila for mapping the regional disparities and research trends in multiple myeloma clinical trials, a focus on South and Southeast Asia. And the first prize in this category goes to Rudra Narayan Swain. Is Rudra Narayan there? On his talk on the role of sequential composite measurable residual disease assessment using PET scan and bone marrow flow cytometry in multiple myeloma patients treated with extended induction and autologous stem cell transplant. And he's from anybody from PGI Chandigarh? I mean, he can take it on.
All of them left in the same flight.
Yeah. Yeah. Thank you, sir. Thank you. May I invite Tapan sir to please come for the last presentation in this category, which is on plasma cell disorders. The third prize goes to Anand Hosali for plasma cell leukemia, a decade of real-world inputs outcomes. Anand Hosali, you're from TMH. TMH? Anand is from Tata Memorial, Mumbai. Congratulations. And the second prize goes to Sandeep Patnaik for his presentation on evolving landscape of AL amyloidosis, a single center experience of 2 decades. From Amrita. Yes, sure. Yeah, okay, come. And the first prize in this category, congratulations. And the first prize in this category goes to Amit Dar on a clinical characteristics and long-term outcomes of POEM syndrome from a tertiary cancer center. Amit Dar is from SGPGI? No, sorry, TMH. Okay, sorry. Oh, that's a relatively violent. Okay, Hamid, I'm sorry about that. Yeah. Thank you. Congratulations. Yeah. Yeah. How could I forget? I valued that. Yeah. Yeah. Okay. Yeah. Thank you so much. Thank you, sir. Congratulations to all the winners. Yeah.
So for the mini oral category, there are a bunch of prizes that we have. So firstly, both, even for the oral and as well as for the mini oral, you will be getting Dr. Tapan Sekia Traveling Fellowship, wherein you have to provide the organizers with the institute NRS, that is nearest railway station of your institute. We will be paying a second AC fare onwards and return, number one. Number two, you also get Dr. Reena Nair Travel Grant, which is 1,500 rupees per day. So we give you a 4,000 rupees, irrespective of whether you are in the hall, you are in the TMC, or you are outside in Calcutta, you get 4,000 per day for all of you who are in the mini oral category and as well as for the oral sessions. Now, irrespective of these 9 people, everybody who were in the mini oral category who presented gets this. over and above these 9 people who won first, second and third prize, irrespective of the rank of first, second, third, all of you get 10,000 rupees over and above Dr. Tapan Saikia Traveling Fellowship and Dr. Reena Nair Educational Grant. So these 9 winners get 10,000 more. But the rules again apply. You have to be a member of Image. You have to publish this data or participate in Image activities as per the grade to get this money. Okay, so that's where we are. Now coming for the next category, which is the e-poster category. Again, in this, we have got 3 subcategories: pathology, clinical and other plasma cell dyscrasias. For this, I would request Dr. Jeevan to come and announce the lucky winners.
So I request Dr. S.S. Roy to come to the rise for the distribution of the prize. So third prize in the pathology diagnostic category, it goes to Dr. Aishwarya Das for a poster on identification of novel biomarkers in bone marrow mesenchymal stromal cells of multiple myeloma patients. From PJ Chandigarh.
Identify your institute, because it's a pride moment for the institute. And they don't get mislabeled. And somebody don't take the credit away for all the hard work of the faculty. Am I right, sir?
Second prize is also going to PGI to Dr. Pankaj Malhotra for their student. So the topic is utility of 68GA pentoxifor for PET-CT for MRD in myeloma.
I'll take the award on his behalf.
And first prize in this category goes to Dr. Manish Kumar Singh. Yeah, you take the prize. For the topic, myeloma patients with normal SFLC at diagnosis are enriched with high risk features in comparison to those who have abnormal FLC.
Anybody from Lucknow will approach them.
Okay. The second category is clinical for e-poster. So the third prize goes to Dr. Shri Vatsa R. Dr. Shri Vatsa. From which institute? Paper. The name of the poster is a retrospective cohort study to assess the benefit of high dose chemotherapy with autologous stem cell transplant.
It's from which institute, beta?
Adyar. Okay. Second prize in the clinical category goes to Dr. Neha Motwani. Dr. Neha from Apollo. Title is a rare complication, that is acute esophageal necrosis in 2 cases of multiple myeloma. Okay. And the first prize go to Dr. Sanju Siriak. From Adyar? Okay. The topic was improved tolerability and outcome with novel melphalan administration technique in autologous stem cell transplant. Okay.
We believe you will give it to me. I have pictorial evidence, madam, from yesterday.
Put it on Twitter.
When are you getting your account, sir? I keep asking you every day.
Yeah. Okay. I request Dr. Mipsang. Dr. Mipsang came here from Nepal. So the third category is the other plasma cell disorders. Third prize goes to Dr. Aradhana Sahu. She is from Tata Medical Center, Kolkata. The topic was allogenic hematopoietic stem cell transplant, the ultimate savior in plasma cell leukemia. Dr. Aradhana is not here? Okay. Dr. Nupur will take the prize. Second prize goes to Dr. Bala. He is also from Tata Medical Center. The topic is a case of monoclonal gammopathy of renal significance presenting as Fanconi syndrome. Thank you, Dr. Mipsang. Thank you. And I want to invite Dr. Rajat Bajaj for distributing the first prize. First prize goes to Dr. Anuhya Prashar. So the topic was retrospective analysis of patients of multiple myeloma associated with AL amyloidosis. Nupur, you can come. Anuhya is there.
Whenever a faculty asks, the students always go to ward only. Heartiest congratulations. Thank you, Dr. Jeevan, for announcing the e-poster categories. Now, quickly coming to what do they get. So, you know the last part of it. Now, you would have by-hearted that part. So, for the first part of it, unfortunately, because of the financial constraints, we are not able to provide the Dr. Reena Nair educational grant or the traveling fellowship to the e-posters. Next year, hopefully, we should be able to provide them as well. But without differentiation between first, second and third rank and the three categories, everybody get 10,000 rupees as an award for all the winners. Conditions apply. And just to repeat it and reiterate it, and so that it gets cemented in your brain, you need to become an image member and you need to publish your work or participate in image activities. So, now the last category, which is a quiz. Sir? Sir, you people have been so good in hosting all of us. So I say the faculty ate away the prizes, the money of the students. So coming back to the thing, so the quiz part of it. So the awards, we already know who are the winners, but the quiz coordinator, Sumit, I think you can re-announce it once more. Please come over the stage. So for the third prize quiz winners, the people, I would request Sanjeevan sir to come and give away the third prize.
So place number third, I've always felt that those who have qualified for the finals also deserve a good hand. It is not easy coming in top 3, but more difficult is coming in top 5 also. So I just reiterate, we'll start on the 5th position first. The 5th position is CMC Ludhiana, Wesley Joyal and Kashika Watts. Probably they did not expect that they'll get something. So they have not come. Anybody from CMC Ludhiana?
Hey, sir, calling on the stage and thanks, giving it. Thanks for coming. So many congratulations. We'll be giving the certificate.
For third, second and first. A special mention for the 4th position also, TMC Kolkata, Sundar Shivale and Suchita Shinde. Now we move on to the 3rd position. It's Madras Medical College, Dr. Karthik A. and Purna Chandran DC. Now for the second prize, I would request if Naveen sir can come to give the prize. Naveen Khatri sir.
Which prize? Second.
The second prize in the quiz. It goes to Team AIMS Rishikesh. The participants were Bibant Shah and Karthik J.
Thank you, sir.
Now for the first prize, I would like to request Dr. Reena Nair ma'am if she can come and please give away the first prize. It goes to Nizam Institute of Medical Sciences, Dr. V. Sai Kiran and Abhinash Hota. Please give a big round of applause. They were also the topmost people in the screening round.
Excellent. Good job.
Thank you, ma'am.
अच्छे announcements.
हाँ good good. मैं अच्छे करूँगा अभी. So now coming to what do the quiz prize winners win. So the second part I will not say. The first part. For the third prize, we have 20,000 rupees. For the second prize, it's 50,000 rupees. And for the first prize, it's 1 lakh rupees for the team. But conditions apply. You have to be image members. And now you don't have anything to publish, but you will participate in the image activities. And this amount is not as cash. This is only for travel fellowship, which we will book your tickets or for your travel to any international conference, myeloma conference, or any international fellowships. And for the winners, if you want us to help you out in international fellowships, we are there to help you out. So that's where we close as far as the prize and the other prizes and the other things are concerned. We welcome you all for the next year's conference, but the conference is not yet over. I would request Dr. Mayur Parihar to come and give vote of thanks. Followed by that, we'll have a group photograph for all those people who stayed back to the last moment of the conference here as a conference at IMC with Madam at the center stage.
Hi, everybody. Well, good. I'll be able to be there in the photograph to start with. Okay, so, we had a fantastic 2.5 days of myeloma, and it all started with the workshop. So in the workshop, we had a lot of faculties who came from different parts of India, and most of them were our students. And all of them have gone and established labs in different parts of the country. So, and some of them had recently joined a job and they had no holidays, and some of them came as a leave without pay. And so I would like to really start with thanking all the old fellows who came for the workshop. It was fantastic. There were a lot of discussions. And we sitting in Tata Medical Center also got to learn from the practices they do. They have changed certain things because some of them are in corporate hospitals and they know how to really save, and do the same tests with the same sensitivity and specificity in a much better way by saving some amount of money. So, it was very nice to see them to come back and give feedbacks back into the institute, and that was very fantastic. First, the whole team, the whole Tata Medical Center team who actually worked together. We've been having these meetings on Saturdays at 9 a.m. regarding the myeloma conference, how to organize it. And I think each and every member of the clinical hematology team, the coordinators, the lab team, the fellows, all of them would come for this meeting, and of course led by Dr. Reena and Dr. Deepak Mishra. And would like to really thank all of them to get their feedbacks. And the best part was some of the best suggestions came from the most junior-most people, and that was fantastic because and that's what I feel. In all meetings you should always have the junior guys because the best ideas always come from them. So would like to thank all of them to be there. Of course, I would like to thank all the national and international faculty for taking out time, spending time with us, their talks, the discussion, discussions both inside the hall and outside the hall. It was a very enriching experience for everybody. Would like to thank all the delegates who've been here, and I can see all of them are sitting. So to be honest, when we were looking at the numbers for the dinner every day, and we said, okay, let's keep halving the numbers from the number of people who come for lunch. And so first day I had actually halved the numbers. And I came and I saw the auditorium was almost full, and I had to call back the caterer that please double the numbers again. And that happened almost. So second day we said, Saturday, most of the people would go out, right? They would be sitting in some pub somewhere. But I came in the evening and I saw the auditorium is full again. Again, I had to call the caterer and then said, can you increase the numbers, please, right? So I would really like to thank all the delegates to be there right from the morning till 8 p.m. It's not easy. And I could see the discussions were still going on. It was such an active interaction. A couple of our clinical colleagues from other departments were like asking me, what do you do for 3 days in myeloma here? So, but I told them, like, come to the auditorium at evening 8 p.m. and you will see the auditorium is full of people. And I'm sure 2.5, 3 days are also not enough for still learning about myeloma. All of us are students and we continue to learn here. Of course, there has been a lot of support from the administration at Tata Medical Center, right from, so the caterer you saw today is the one who actually serves, from whom you have been eating is the one who serves us food every day. He's our hospital canteen guy, and they really upped their game, and I wish they could give us the same food every day, what we ate in the conference, and all of us were really surprised, but it was, they really upped their game, and they really kept adjusting to the change in the number games that we played with them on a daily basis. Of course, the accounts, the sales team, the HR team, the security, the housekeeping, everybody were involved, and they really helped us. And they were actually very forthcoming. They would come and say, sir, do you need electric connection near the lunchroom? Do you need lights? You can have dinner there only. And we said, no, there would be mosquitoes and insects, And then we changed our plan to have the dinner there. But what I want to say is there was such proactive enthusiasm from everybody in Tata Medical Center to help us actually organize this meeting. So I'd like to thank all of them. Have I missed anybody else?
Yeah, we have missed that.
Who is it? Yeah. Okay, so whomever I have missed, Jeevan is going to talk about them.
Thank you, Dr. Mayor. You have covered almost everyone. So I want to add few more things. Like we are thankful to our management team, the event management team, River Roots. So with the help of there was no problem in audio visuals. So a big clapping for them. And all the halls, we have used at a time like 3 or 4 halls, but all halls have worked very well. And a special mention goes to our pharma sponsors. So without whose support, we cannot do this conference. So this year we have received a support from Johnson & Johnson, Dr. Reddy's, Netco Lab, Intas, Cipla, GSK, Hetero Healthcare, Amcure, Fresenius, Ceylon, Lupin, Glenmark, Samarth, and Zydus. So with the help of these pharma supports, we are able to do this conference. For this conference, as Dr. Mayur has already told, that we are planning from last 6 months under the supervision of Dr. Reena Nair. So we are all thankful to ma'am for planning wonderfully for this conference and making this a success. So I'm thankful to all. Safe travel and best wishes. Yeah. So we can come here for the photograph.
The projection is not coming. It's off. It's off. Odds off.